Part A. Extract 1. Questions 1 to 12. You hear a plastic surgeon talking to a patient called Mihira. You now have 30 seconds to look at the notes.
Hi Mihira, come on in. Have a seat. So, what brings you here today?
Hi, doctor. Well, it's kind of embarrassing, but I've been really struggling with my weight for a few years now. I've been feeling overweight, and it seems like no matter what I do, the numbers on the scale keep going up. It's definitely affecting my health and self-esteem.
Thanks for being so honest with me, Mihira. It sounds like you've been putting in a lot of effort to manage your weight. Can you tell me a little more about what you've tried so far?
I feel like I've tried everything, all of those regular stuff, fancy diets, even joined a gym with a personal trainer, but nothing seems to stick. I just keep gaining weight.
I understand, Mihira. It can be incredibly frustrating. But before we consider a surgical option like bariatric surgery, there are some things we need to weigh first. Let's talk about your overall health and see if there are non-surgical approaches that might be a good fit for you. Mihira, any pre-existing medical conditions you'd like to mention?
Not really. I mean, I get a cold maybe once a year, but other than that, I'm generally healthy.
Okay, good to know. What about your lifestyle? What kind of work do you do?
I work in tech as a software developer. So, yeah, it's a lot of sitting at a desk, staring at a screen all day.
Makes sense. Has weight been an issue in your family? Anyone you're close to who struggles with it?
Yeah, actually. My dad, bless his heart, has type 2 diabetes, and my mom, well, she's always been a bit on the curvy side.
Okay, that's helpful information. Are you currently taking any medications, or maybe seeing a nutritionist or anything for weight management?
No, nothing like that right now. Like I said, I've tried all these fad diets. Cabbage soup one was awful, and different exercise programs, but nothing seems to give me lasting results. I lose a few pounds, then it all comes back, sometimes with a friend.
I hear you. Tell me more about this weight gain. When did you first notice it becoming a problem?
Honestly, it probably started after college. I moved to a new city and a new job, and everything felt so hectic. I was living on takeout, barely sleeping, and definitely not exercising.
What else have you gained besides weight?
Well, a lot. Now, it's gotten to a point where I just feel sluggish all the time. My knees are killing me, and even climbing the stairs to my apartment winded me the other day.
Those are all valid concerns, Mihira. While surgery can be an option down the line, it's definitely a major decision. We need to explore all possibilities first. But listen, we have to consider talking to a registered dietitian, who can create a personalized plan based on your lifestyle and preferences, not some crazy crash you have tried before.
You know, I hadn't even thought of that. Surgery seemed like the only way out, but I guess there are other options.
Absolutely. Let's work together to find a solution that doesn't involve surgery. We can get you set up with a dietitian, figure out a realistic exercise routine you can stick with, and maybe even address some of the stress factors that might be contributing to your weight gain.
Extract 2. Questions 13 to 24. You hear a pediatrician talking to a parent called Mihira. You now have 30 seconds to look at the notes.
Hi Mihira, come on in. How can I help you today?
Hi, Dr. Tony. It's about my son Marley, actually. I'm a bit worried about his growth lately. He seems to be much smaller than other kids his age, and I'm concerned there might be some kind of delayed growth happening.
Marley, huh? How old is he now?
According to his growth chart, he's only the size of a typical 4-year-old, but he just turned 5 last week. This makes us wonder if there's something going on with his growth, or maybe we just celebrated the wrong birthday for the 4th year in a row.
I understand that can be frustrating. Tell me more about what's been happening.
Doctor, you know how kids are, growing like weeds 1 minute, all limbs the next. But lately, it just seems like everyone else has shot up, and Marley.
I understand your concern completely, Mihira. Growth is a big part of this stage. Can you tell me a little more about Marley's day-to-day? Does he seem generally healthy?
Oh, absolutely. No fevers or anything like that. He loves going to the park with his friends, but he mostly sticks to the swings and the little slide. Doesn't seem too interested in climbing the jungle gym or racing around like the other kids.
Interesting. Have you noticed any changes in his appetite or sleep lately? Maybe his energy levels?
Now that you mention it, he has been a bit pickier with his food. Less excited about vegetables these days, and seems to gravitate more towards pasta and bread. Carbohydrate king, that one.
Kids, huh? But seriously, how about sleep? Does he seem well rested in the mornings?
He sleeps through the night most of the time, but he can be a bit sluggish getting going in the mornings. Take some coaxing to get him out of bed sometimes.
Alright, anything on the family history side? Any growth issues or nutritional deficiencies that you know of?
Honestly, not that I'm aware of. My husband and I were both on the taller side growing up.
Well, genetics can be a funny thing. Let's take a look at Marley, shall we?
Yes, sure.
Mihira, Marley seems like a bright and active boy. However, based on his measurements, he does fall a little below the expected height percentile for his age. But don't worry, there are things we can do.
Oh, thank goodness. What can we do to help him grow, Dr. Tony?
Well, there are a few things. First, we could schedule a consultation with a dietitian. They can create a more balanced diet plan for Marley, making sure he gets all the nutrients his growing body needs.
That sounds interesting.
Absolutely. On top of that, we can encourage Marley to participate in more physical activities that promote growth and development.
Definitely, and like what?
Maybe consider enrolling him in a swimming class or even a gymnastics program.
Those are both great ideas. He loves splashing around in the pool, and he's always been fascinated by those gymnasts who can bend and twist like pretzels.
Perfect. We'll reevaluate Marley's growth in a few months to see how he's progressing. In the meantime, if you have any questions or concerns, please don't hesitate to call the office. We're always here to help.
Thank you so much, Dr. Tony. You've been a lifesaver. I feel so much better now knowing there are steps we can take to help Marley grow strong and tall.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. You'll have time to read each question before you listen. Now look at question 25. You hear a nurse called Mihira talking to a colleague. Now read the question.
Hey Daniel, have you reviewed the new sign-off protocol for discharge medications? There are a few nuances that might trip people up.
I glanced through it, Mihira, but it seemed straightforward. Just confirming the patient's details and verifying prescriptions, right?
Well, not exactly. The key change is that we now need two separate verifications, one for dosage accuracy and another for potential drug interactions. Previously, we only flagged interactions if the patient was on multiple medications, but now it's mandatory for all cases, even single drug prescriptions.
That's a shift. What if the system doesn't flag an interaction automatically?
Then we manually cross-check with the updated database, not the old one. That's where mistakes happen. Last month, a colleague relied on the outdated system and missed a critical beta blocker interaction.
Got it, Mihira. And what about high-risk patients? Any extra steps?
Yes, they require a third sign-off from the senior pharmacist, but only if their condition is unstable. Stable chronic cases follow the standard process.
Now look at question 26. You hear a nurse called Mihira talking to a doctor. Now read the question.
Hey, just a heads up about the new admission in Bay 5, Mr. Collins. He's been flagged for multiple comorbidities, diabetes type 2, early-stage renal impairment, and borderline hypertension. His notes say he had a mild MI 2 years ago, but there's no mention of follow-up cardiology review.
That's a lot to juggle, Mihira. What's the immediate concern?
Well, he came in with shortness of breath and a productive cough. The GP suspected pneumonia, but there's no definitive diagnosis yet. Radiology's backed up, so we're managing symptomatically for now.
So, oxygen and empirical antibiotics, I assume?
Precisely. But here's the tricky bit, he's on metformin and lisinopril, both of which could be problematic if his renal function deteriorates. And he's already borderline. I've flagged it for the consultant, but no action yet.
That's a bit unsettling. Sounds like he might need more proactive oversight.
Exactly. I'm keeping a close eye, but honestly, I feel like we're being reactive rather than preemptive here.
Yeah, Mihira, not ideal. Let me know if you want me to escalate this during the afternoon round.
Now look at question 27. You hear a nurse called Mihira talking to a junior nurse. Now read the question.
All right, before you insert the cannula for the patient in room 12, just be aware, she's got a history of poor venous access. Last week, 3 attempts failed before they switched to ultrasound guidance. Oh, that's good to know, Mihira. Should I try the forearm first? Normally, yes, but in her case, I'd avoid the left forearm altogether. That arm's post-mastectomy, so lymphatic drainage is compromised, risk of lymphedema if we cannulate there. Right, I remember now. What about her right hand? That's where it gets tricky. She's got an old cannula site there, recently removed, and mild phlebitis noted. So, best avoid that area too. So Mihira, we're left with the antecubital fossa on the right? Ideally, yes. but try a warm compress first to dilate the vein. And if it still doesn't look promising, ask the registrar about a guided attempt. We don't want multiple failed insertions again. It stressed her out last time. Understood. Thanks for the heads up.
Now look at question 28. You hear a doctor called Mihira talking to a nurse. Now read the question.
Just a quick update on the new admission in room 9. He's a 68-year-old male, admitted post-fall, but the fall seems secondary to a syncopal episode. His bloods show mild anemia and borderline troponin levels, and his ECG is inconclusive. Nothing obviously ischemic, but not entirely normal either.
That's a bit ambiguous. Any known cardiac history, Mihira?
None documented, but his wife mentioned he's been unusually fatigued for weeks. No chest pain, but a few dizzy spells. We've requested an echo and Holter monitor to rule out any arrhythmias.
Okay. And what's the plan for today?
Keep him on telemetry, monitor vitals closely. I've asked physio to hold off mobilizing until we clarify the cause of the syncopal event. Also, we'll repeat the troponins in 6 hours, just to be safe.
Got it, Mihira. So, mainly observation for now?
Observation, yes, but targeted. We're trying to determine if this was cardiac in origin or just orthostatic. Either way, we need to be cautious before proceeding.
Now look at question 29. You hear a physiotherapist called Mihira talking to a doctor. Now read the question.
I've been seeing Mr. Hayes for the last few days, and I think his recovery is progressing, but there are a few things I'm still concerned about. His range of motion has improved in the knee, but he's struggling with his gait. The left leg, especially, seems weak, and he's favoring it during walking.
Is he experiencing pain or just weakness?
There's no significant pain. The weakness is more pronounced when he stands from sitting or tries to take longer steps. The quads are still quite underactive, and while we've been working on strengthening, he doesn't seem to be making the progress I expected.
Interesting. Mihira, have you noticed any swelling or signs of instability around the joint?
No, there's no swelling, but there's a slight tremor in his leg when he tries to stand up quickly, which could suggest a coordination issue. I'm wondering if we should investigate further, maybe with a neurology consult, just to be sure.
I agree, Mihira. It might be worth ruling out any neurological causes before we push him further. Let's proceed with the referral.
Now look at question 30. You hear a social worker called Mihira talking to a GP. Now read the question.
I've been following up with Mrs. Peterson for the past few weeks. She's making some progress with her recovery from the stroke, but there are a few concerns. She's been struggling with memory recall and seems very withdrawn. Her daughter mentioned that she's become more anxious about leaving the house.
That's concerning. Has she mentioned anything specific that's causing the anxiety?
She hasn't directly said much, but it's clear that she's worried about her ability to manage things on her own outside the house. I've noticed she gets overwhelmed even with small tasks, like going to the local shop. She's also been having difficulty keeping track of her medications, which worries me.
That's understandable, considering her cognitive changes. Have you had any discussions about community support or additional home care?
Yes, we're in the process of arranging a home care worker to assist her, especially with medication management. But I'm still concerned about the ongoing anxiety. It might be helpful to consider a referral for a psychological evaluation, perhaps to address her fears about independence.
I agree, a referral would be useful. Let's proceed with that and see how she responds.
That is the end of Part B. Now look at Part C. Part B. In this part of the test, you'll hear 6 different extracts. You'll have time to read each question before you listen.
Welcome to Healthcare Insights. Today, we have the pleasure of speaking with Mihira, a highly experienced pediatric nurse with over 15 years dedicated to caring for children in various hospital settings. Mihira, thank you so much for joining us to share your perspective on the unique demands and rewards of your profession.
Thank you for having me, David. It's a pleasure to be here and discuss a field I'm deeply passionate about.
Let's start with the basics, perhaps. Many nursing specialties exist, each with its own focus. From your extensive experience, Mihira, what truly sets pediatric nursing apart? What makes it feel special, distinct from, say, adult care or geriatrics?
That's a great question to begin with. Pediatric nursing is fundamentally about potential and resilience. You're working with individuals at the very start of their lives, often navigating complex health challenges. The unique aspect isn't just treating illness, it's fostering growth, development, and healing in a way that considers their entire future trajectory. Unlike adult care, where you might manage chronic conditions with established patterns, with children, you're constantly adapting to rapid developmental changes, physically, emotionally, and cognitively. There's an incredible sense of hope inherent in the work. Witnessing a critically ill child regain strength, learn to cope with a chronic condition, or simply smile despite discomfort, those moments are profound. It's also the depth of the relationship you build, not just with the child, but with their entire family unit. You become a trusted partner, an educator, and an advocate, navigating incredibly vulnerable times alongside them. That multifaceted relationship and the focus on future well-being, seeing them transition back into their lives, possibly growing up and thriving, that long-term impact feels quite distinct and incredibly rewarding. The trust families place in you during their most stressful moments is a profound responsibility and privilege.
That emphasis on potential and the family unit certainly paints a vivid picture. But Mihira, alongside those rewards, must come significant hurdles. Could you elaborate on what you find to be the most challenging aspect of being a pediatric nurse?
Without a doubt, the emotional weight is the most significant and persistent challenge. You're dealing with vulnerable children, sometimes facing life-limiting conditions or severe trauma, and the suffering you witness can be deeply affecting. Maintaining professional boundaries while offering genuine empathy is a constant balancing act. It's particularly tough when, despite everyone's best efforts, a child doesn't recover. Those situations leave an indelible mark. Beyond the purely emotional, communication barriers present a unique challenge. You might be caring for a preverbal infant who cannot tell you what's wrong, or a toddler whose fear manifests as resistance, or even an adolescent struggling to articulate complex feelings. Added to this is often the intense anxiety and stress of the parents or caregivers. You're not just managing the child's needs, but also navigating the family's emotional responses, providing support, translating complex medical information, and sometimes mediating difficult dynamics within the family itself. It requires immense patience, sophisticated communication skills, and emotional resilience to handle these layers effectively day in and day out. Managing parental expectations, particularly when faced with difficult prognosis, demands exceptional sensitivity and honesty.
That interplay between the child's needs and the family's emotional state sounds incredibly complex. It suggests that a pediatric nurse needs an exceptional level of awareness. Mihira, how vigilant or conscious does one need to be moment to moment in this role?
Vigilance is absolutely paramount. It's woven into the very fabric of pediatric nursing. Children, especially infants and toddlers, can deteriorate incredibly quickly, often with very subtle signs. You need hyper-awareness, constantly observing for minute changes in breathing patterns, skin color, activity levels, feeding tolerance, or even subtle shifts in their cry or responsiveness. Missing a subtle cue can have significant consequences. This isn't just about monitoring vital signs on a machine. It's about intuitive assessment, understanding baseline behaviors for that specific child, and recognizing deviations swiftly. Furthermore, medication safety is critical. Pediatric dosages are often calculated based on weight, requiring meticulous double-checking and administration accuracy. There's virtually no room for error. You also need to be acutely conscious of the environment, ensuring safety, minimizing stressors, and creating a child-friendly space even within a clinical setting. It extends to anticipating needs, predicting pain before it escalates, recognizing thirst or hunger in a nonverbal child, understanding developmental needs like play or comfort. You are, in many ways, the child's primary advocate, constantly assessing and interpreting their needs to the wider healthcare team, especially when the child cannot speak for themselves. This level of sustained, multifaceted awareness is non-negotiable.
Mihira, you mentioned the intensity and the need for constant vigilance. This leads me to wonder how pediatric nursing stacks up against other nursing specialties. Is it inherently tougher, or just different?
Tougher is subjective, as every nursing field has its intense pressures. Think of emergency rooms or intensive care units for adults. However, pediatric nursing possesses a unique blend of stressors that demand a specific skill set and emotional constitution. The emotional investment, as we discussed, is often deeper and more complex due to the vulnerability of the patients and the intense family involvement. Dealing with the ethical dilemmas surrounding child welfare or end-of-life care for a young person carries a particular kind of weight. The communication challenges are also distinct. You need to constantly adapt your approach, based on developmental stage, requiring creativity and patience that might differ from communicating with adults who can typically articulate their needs more clearly. The need for precise calculations and understanding of pediatric physiology and pharmacology adds another layer of complexity. So, while I wouldn't definitively label it tougher across the board compared to, say, managing multiple complex adult comorbidities in an ICU, the nature of the challenges, the deep emotional resonance, the family dynamics, the developmental considerations, the communication barriers, makes it exceptionally demanding in its own specific way. It requires a unique resilience and a very particular set of interpersonal and clinical skills.
You've touched upon communication barriers several times, particularly with preverbal or nonverbal children. Mihira, how do you effectively evaluate a child's well-being or assess their condition when they can't simply tell you what's wrong?
That's where keen observational skills become absolutely critical. You rely heavily on a combination of physiological indicators and behavioral cues. Physiologically, we monitor heart rate, respiratory rate, and effort, oxygen saturation, blood pressure, temperature, and skin perfusion very closely. Changes in these parameters are often early indicators of distress or deterioration. Behaviorally, we become detectives. We assess their level of interaction. Are they making eye contact? Are they engaging with toys or caregivers as they normally would? A change in interaction is a huge red flag. We observe their body language. Are they listless, irritable, tense, guarding a specific area? Facial expressions are key. Grimacing, furrowed brows, or a lack of expression can indicate pain or discomfort. We learn to interpret different types of cries. Is it a pain cry, a hunger cry, a tired cry? Experienced nurses develop a good ear for this. We also use standardized pain assessment tools designed specifically for nonverbal children, which rely on observing these behaviors, like the FLAC scale, face, legs, activity, cry, consolability. Crucially, we involve parents or primary caregivers intensely in this assessment. They know their child best and can often detect subtle changes in behavior or routines that might escape someone less familiar. Their input is invaluable in piecing together the clinical picture.
That's fascinating, Mihira, combining objective data with behavioral interpretation and parental input. Could you elaborate further on the specific techniques you employ during the actual patient assessment process, adapting them for children?
Assessment in pediatrics has to be flexible, opportunistic, and developmentally appropriate. You can't just walk in and perform a rigid head-to-toe assessment like you might with a cooperative adult. For infants and toddlers, we often start with the least intrusive parts first: observation from a distance, listening to their heart and lungs while they're calm or even asleep in a parent's arms. We utilize play, using a stethoscope as a telephone, letting them examine a doll first, or using bubbles or toys for distraction during uncomfortable procedures. Explanations need to be simple, concrete, and honest, tailored to their cognitive level. For school-age children, you can involve them more directly, explaining steps in simple terms, giving them choices where possible. Should I listen to your heart first or check your tummy, which fosters cooperation and reduces anxiety. With adolescents, privacy and respect are paramount. Explaining procedures clearly and addressing their concerns directly is essential. Regardless of age, building rapport quickly is key. A gentle voice, a calm demeanor, getting down to their eye level, and involving the parent for comfort and security are standard techniques. We also modify the sequence. For example, examining ears and throat, often the most distressing parts for a young child, is usually left until the very end. It's about blending systematic clinical assessment with psychological sensitivity and creative adaptation to get the information needed while minimizing distress.
Mihira, this has been incredibly insightful. You've painted a detailed picture of the complexities, the challenges, and the profound rewards of pediatric nursing. Thank you for sharing your expertise and experiences with us today on Healthcare Insights.
It was my pleasure, David. Thank you for the opportunity.
Extract 2. Questions 37 to 42. You hear a presentation by Dr. Larry Holmes about the Mihira Care Dermatopathology Laboratory. You now have 90 seconds to read questions 37 to 42.
Good morning, everyone. I'm Dr. Larry Holmes, lead dermatologist and head of the Dermatopathology division here at Mihira Healthcare Institute. It's a genuine pleasure to speak with you today about a cornerstone of our commitment to excellence in skin health, the Mihira Care Dermatopathology Laboratory. For too long, definitive diagnosis in complex dermatology cases has relied on external facilities, often leading to delays and fragmented care pathways. We recognized a critical gap: the need for rapid, highly specialized, in-house analysis of skin biopsies to directly inform treatment decisions and improve patient outcomes right here within the Mihira care ecosystem. Establishing this dedicated lab wasn't just about convenience, it was about elevating the standard of dermatological practice, enabling closer collaboration between clinicians and pathologists, and ensuring our patients receive the most accurate diagnoses in the shortest possible timeframe. This immediacy is crucial when dealing with potentially malignant conditions or complex inflammatory dermatoses, where timely intervention significantly impacts prognosis. The ability to have direct, real-time consultations between the treating dermatologist and the interpreting pathologist about a specific slide is invaluable and something often lost when samples are sent afar. Now, a laboratory is only as good as the minds within it. Our dermatopathology team at Mihira Care is a carefully curated group of specialists dedicated solely to the microscopic interpretation of skin diseases. Leading the pathology side is Dr. Evelyn Reed, a board-certified dermatopathologist with extensive experience in diagnosing rare and complex skin conditions, including melanocytic lesions and cutaneous lymphomas. Working alongside her are two highly skilled senior histology technicians, Mr. David Chen and Ms. Sarah Jenkins, who manage the meticulous processes of tissue processing, embedding, sectioning, and staining, ensuring the highest quality slides for interpretation. We also have a dedicated lab manager, Ms. Olivia Martinez, who oversees operations, quality control, and liaisons with clinical departments, ensuring seamless workflow. Crucially, this core team works in constant dialogue with our clinical dermatology staff, including me and my colleagues. This integrated approach ensures that the microscopic findings are always interpreted within the full clinical context of the patient, a synergy vital for accurate diagnosis and optimal patient management provided by Mihira Care. To support this expert team, Mihira Healthcare Institute has invested significantly in equipping the lab with cutting-edge technology. We possess advanced automated tissue processors and stainers that ensure consistency and efficiency. Our microtomes allow for ultra-thin sectioning, critical for detailed morphological assessment. Beyond standard hematoxylin and eosin (HNE) staining, the lab is fully equipped for a comprehensive panel of special stains, PAS for fungal elements, GIMSA for certain microorganisms, Moissan's trichrome for connective tissue analysis, and more. Furthermore, we have capabilities for direct immunofluorescence (DIF) testing, essential for diagnosing autoimmune blistering diseases like pemphigus and pemphigoid. We are also in the process of validating immunohistochemistry (IHC) markers, which will allow for more precise classification of skin tumors and inflammatory conditions by detecting specific protein expressions within the tissue samples. This comprehensive suite of diagnostic tools allows us to tackle a vast range of dermatological conditions, from routine screenings to the most diagnostically challenging cases referred to Mihira Care. The physical layout is designed for optimal workflow, sample integrity, and adherence to stringent safety protocols. What is the ultimate purpose driving the Mihira Care Dermatopathology Lab? Our primary aim is diagnostic precision. We strive to provide clinicians with the most accurate, detailed, and clinically relevant interpretation of skin biopsies possible. This directly translates into better patient care, ensuring appropriate treatment is initiated promptly and unnecessary or incorrect therapies are avoided. Beyond individual patient diagnostics, the lab aims to be a center for education and research within Mihira Healthcare Institute. We plan to host regular clinico-pathological correlation conferences, fostering learning among dermatology residents, fellows, and attending staff. We also aim to contribute to the broader field by participating in research studies, analyzing tissue samples for clinical trials conducted at Mihira Care, and potentially publishing findings on interesting or rare cases encountered. Ultimately, our goal is to enhance the diagnostic capabilities across the entire institution, making Mihira Care a leader in comprehensive skin health management, underpinned by reliable and sophisticated pathological analysis. Accessing the services of the Mihira Care Dermatopathology Lab has been designed to be streamlined and efficient for clinicians within our network and for referring physicians. For internal dermatology and other relevant departments within Mihira Healthcare Institute, biopsy specimens are collected using standardized kits available on all wards and clinics. These kits contain appropriate fixative, usually formalin, and detailed requisition forms. The requisition form is critical and must include comprehensive clinical information, patient history, description and location of the lesion, differential diagnoses, and specific questions for the pathologist. Samples are transported to the lab via our internal courier system following strict handling protocols. For external physicians wishing to utilize Mihira Care's expertise, they can request biopsy kits and requisition forms directly from the lab via phone or our secure online portal. Completed samples can then be sent via approved medical courier services. Reports are typically generated within 2 to 4 working days for routine cases, with preliminary results available sooner for urgent requests, communicated securely through our electronic health record system or encrypted email for external referrers. Clear communication channels are maintained for any queries regarding specimen requirements or results. Looking ahead, we have ambitious plans for the continued growth and enhancement of the Mihira Care Dermatopathology Lab. As I mentioned, the full implementation and expansion of our immunohistochemistry panel is a key short-term goal. Beyond that, we are actively exploring the integration of digital pathology. This involves high-resolution slide scanning, allowing for remote viewing, consultation, and potentially the application of artificial intelligence algorithms for diagnostic assistance in the future. This technology could facilitate easier second opinions and enhance our educational activities significantly. We also aim to develop molecular pathology capabilities in-house, particularly for melanoma prognostication, e.g., mutation analysis, and potentially for diagnosing certain genodermatoses. Furthermore, we plan to strengthen our research collaborations, both internally within Mihira Care and with external academic institutions, to contribute more actively to advancing the understanding and treatment of skin diseases. Continuous quality improvement initiatives and pursuing further accreditation will remain central to ensuring our lab operates at the highest possible standard, solidifying Mihira Care's reputation for excellence. Thank you.